So last talk, guys, and I'm not going to talk too much. Great. So, yeah, elbow exam. Now, it's the last talk, you guys want to go, but I do want you to pay attention. And that's because when you finish your exams and go into practice, you have to every day decide, am I looking at a critical issue or just a regular issue? Is this a normal problem or a really bad problem? And that's what a lot of clinical practice becomes. The other part is doctors have big egos, and survival means dancing between this and doing your job. So for you to survive, you have to have a set of skills that other people don't have. You should know what they don't know, so you can change the game as being played. And we'll talk about it in this talk. If you can't do that, your reputation will end up in the toilet. So objectives for this talk are review relevant preclinical information, divide conditions in domains, and interpret exam by domains. You know anatomy? I'm not going to tell you anatomy. But when we look at anatomy, we can break it down in 3 different domains as generators of pain for the elbow. The first would be the enthesis. The next would be nerves around that region, or more proximal, and then bone. Having said that, these are the common diagnoses that come under these different domains. So enthesis, we have lateral and medial epicondylitis. With nerve, we have cubital tunnel, radial tunnel, Parsonage-Turner syndrome, and C6 radiculopathy mimicking elbow pain. With bone, you have all these strange conditions. And when you look at this, it can be so overwhelming. What am I actually looking at when I'm seeing them in practice? So we're going to sort that out. The first thing is to know how common these things are. So if you take enthesis and enthesis pathologies, lateral epicondylitis is about 400, 700 per 100,000 people total. That is the most common cause of elbow pain. Next is medial epicondylitis with about 30 to 60 per 100,000. And that is your enthesis issues. Next is nerve issues. Now C6 radiculopathy mimicking elbow pain is going to be very common. That's 30 per 100,000 versus cubital tunnel at 25, radial tunnel at 3, and Parsonage-Turner at 3 per 100,000 also. The last is bone, and it's kind of a bunch of weird conditions. Osteoarthritis being the most common with 30 to 40 per 100,000. Gout in the elbow, 80 to 40. Septic arthritis, 1 per 100,000. Myositis ossificans, again, 1 per 100,000, because we're PMR, we get it all the time. Right? Hemophilic arthropathy, if you do hemophilia work, you're going to see a lot of it, but otherwise 5 per 100,000. Synovial osteochondromatosis, 1 per 100,000. Pigmented villonodular synovitis, 0.18. This is how common these conditions are, and they're not really that common. That's the point with all these numbers. But tumors around the elbow, that changes everything. So osteochondroma is 10 per 100,000, lipoma 5 per 100,000, osteosarcoma, Ewing sarcoma, chondrosarcoma 0.5, and soft tissue sarcomas 0.1. So when you get a patient, you're thinking about these things that could be weird diagnoses. Keep in mind how common they actually are. It's not to say they don't exist, but there could be more common things actually happening. Having said that, we want to really learn to sort out whether these things are common or uncommon. Are we looking at a common case or not so common case? So common cases, you've seen the numbers already. I'm just reframing it here. Lateral epicondylitis, medial epicondylitis, C6 radiculopathy, osteoarthritis, myositis because we're PMR, and gout. Right? The uncommon stuff is pretty much everything else. It's not saying it's less important. It's just these are the more common cases. The thing is, for you to become sharper as a clinician, you have to be able to detect patterns. And pattern recognition means you should know what you're looking at. So common conditions, they really look like what they are. Uncommon conditions have variable presentations or more than one feature that don't really match that diagnosis. But having said that, we have to think about relevant history. again, it's been drilled in over and over again. History is everything, and we're going to do that more. History really is everything, because with the common conditions, especially in the enthesis, it's going to be pain at this site that's worse with activity. We don't really have uncommon entheses problems, but then with nerve, it's a neck pain that shoots into the arm, and there's an elbow pain, versus the uncommon nerve conditions, which may have weakness outside of that one nerve's distribution. The other thing is bone problems. So it could be worse with activity. It may or may not be made worse with particular foods, but the uncommon stuff may or may not have a fever history or a family history. So you're looking at these kind of trends that come up in the history to see what you're thinking. Should this be a common diagnosis? Should it not be common? And again, relevant exam. So enthesis issues will usually have pain on palpation, but the determinant jerks will be normal. The nerve conditions will have wasting in that myotome with decreased tendon jerks, versus the uncommon in nerve conditions will have weakness outside of that myotome or the nerve's distribution. And again, bone, the common kind of stuff is pain with range of movement, warmth, swelling, single and multiple joints. But when it doesn't match that, it's going to be something really uncommon, so be careful. This would not be elbow exam if I didn't talk about elbow exam, so we're going to go through this. You have to observe and inspect the joint, look at the alignment, carrying angle, swelling, muscle wasting, scars, resting posture. Then you have to look at the bony landmarks for the epicondyles, the olecranon, the radial head, tendon insertions, pain localization, duodenals at the cubital tunnel, radial nerve, radial tunnel tenderness, range of movement, end feel, strength testing. Again, look and match to the myotome and the dermatome and the nerve's distribution. This really helps you sort out what you're looking at. The special tests that help us understand we're looking at a specific condition, like Cosen's test, Mills test, Maudsley's test, valgus, varus strain, chair push-up, pivot shift, nerve compression tests. And lastly, sensory distribution testing, reflexes, upper limb tension test, as you've seen before today morning. So it's not just about testing, though. Testing has a problem, and we're going to use Cosen's test as an example. So you can do a test, but it doesn't mean that when it's positive you actually have the condition. So with Cosen's test, 78 to 83% of the time when you do this test and the condition is positive, you will have a tennis elbow. 17 to 22% of the time, it will still be positive, but it's going to be a different condition. Something mimicking, looking like a tennis elbow, but it's actually not. So you have to be careful. These tests are not perfect. You can do multiple ones to cross-confirm, but no one test is perfect. The other side of it is, 80 to 90% of the time, this will not find tennis elbow when it is not present. The other side of it is, 10 to 20% of the time, it will not find tennis elbow when it is present, and that's a concern. Your history makes you think it's tennis elbow. You do the test, it comes out negative, but everything makes you think, no, this really is tennis elbow, but the test is wrong. So this is common, that's common, that's common. This is not so common. So when we talk about outcomes as common and uncommon, you get a patient who has a complaint. They go to the primary care doctor. The primary care guys are pretty good. If it's a common condition and they get an optimal outcome, everyone's happy. Yay, done, right? Primary care does get stumped at times. Sometimes they don't get the best outcomes. Now, primary care doctors have an option to send it to a subspecialist. Sometimes primary care knows this is something really weird, it's not my regular thing, subspecialist straight away. But either way, subspecialist does what they do, fancy tests, big injections, all the special medications, and outcomes, right? So if a subspecialist gets a good outcome, everyone's happy. We got a diagnosis, we got the right treatment, everything's done, good. It's not always the case, though. Sometimes they do get mixed and poor outcomes. The answer that some subspecialists will give is live with it. Now, we live in the modern age. People know there's more options. They're not going to be happy with that. So, if the patient is not happy with being told to live with the problems that they have, You could make it someone else's problem. And whose problem? Ours. Right? This is where we come into private care. Right? So if you don't know how to handle these situations, you're going to end up ordering the same tests over and over again, repeating the same pills and injections, and everybody will wonder what the heck you're doing. So you have to have a set of skills that no one has. We're going to repeat the same thing, Cosen's test. Bear with me. So Cosen's test positive, tennis elbow positive, undisputed tennis elbow. If you can't figure this out, you belong in there. And everybody learns it's okay, you get better, right? But all you need is a brain that really works. You know what you're seeing, you make a diagnosis, it's done, right? Cosen's negative, tennis elbow negative, it's not tennis elbow if you can't figure it out, yeah? But again, clinical skills will help you understand what is not and what is. You do it enough, you get better at it. Cosen positive, tennis elbow is not there. That's a differential diagnosis, but luckily, hey, if you can't figure out, you got a problem, but labs and radiology will actually help you figure that out. They will tell you what you can't see with your own mind and eyes, right? The hard part, like I said before, is Cosen negative, but there's actually a tennis elbow, but the test isn't really going in that favor, right? And it's a weird presentation of a common condition. So this is where you find doctors fighting each other. I think it's this, you think it's that, I'm right, you're wrong, whatever, right? To survive here, you need to have a brain that works. And that means you can change the game as it's being played. What does that mean? You have to handle uncommon outcomes in common conditions. And the price to pay to play that game is you have to keep asking why. Why? Why am I saying this? Why am I saying that? Why did it look like this? Why did it not look like that? Because not all people with diseases have the same listed symptoms. But it's your job to get the right diagnosis and the optimal outcome. So what remains after all of this, right? Why is this the case? Why do we have cases where there is a condition but the test is not showing it? Sometimes the person's come in too early, so the test can't actually show it. Sometimes they come in too late. It's so far gone the test won't show you anything. Sometimes they're already on medications. Medications are blocking the effect of showing the test positive. Sometimes it's psychosomatic, sometimes it's lifestyle factors. Other times it's myofascial chains. And what are those? The muscles in the body don't work independently, they work together in chains that run across the body. So if you have a dysfunction in one place, think to look more proximal, more distal, because that could be what's actually making this happen. This is how you change the game as it's being played. Myofascial chains are plenty throughout the body. I'm going to name a few here for you. It's your job to go and read. Superficial front line, back line, spiral line, there's so many lines across the body, but these muscles link together to produce functions that we see in the body. So in example, say you have a dysfunction in the proximal muscles, like in the cervical spinal column, the shoulder girdle, it can make a scapular dyskinesis. This will alter the way the elbow normally works and eventually manifest as a tennis elbow. Right? If the person's hand or position is in the wrong position, they're always driving a mouse all day long, right? It's going to change the way the elbow gets loaded and the stress patterns in it, manifesting as these problems that we see. And this is why you can give a person pills and injections, but they come back with problems again. If you thought that was bad, it only gets worse. You see, the thing is, what we look at as a condition is not just a condition, it's part of a continuum. What we